Good morning. We'll go ahead and call our next session to order. We're very pleased that you all are here with us this morning. We have a number of talks to present to you in the next hour and a half. We'll begin with the Kent Trinkle Education Lectureship. As many of you know, the Kent Trinkle Education Lectureship is an integral part of the programming for this meeting. We always have a lecture that honors the memory of Dr. Trinkle, and it's a lecture that is focused on surgical education. This year we're particularly honored to welcome Dr. Bart Griffith to give the lecture. Dr. Griffith is the Thomas E. and Alice Marie Hales Distinguished Professor of Surgery at the University of Maryland. He trained at the University of Pittsburgh Medical Center under the mentorship of Henry Bonson and Thomas Starzl. It was there that he established both a basic science and a clinical interest in organ replacement. Programs in mechanical circulatory support evolved from some of the earliest use of the Jarvik 7 total artificial heart as a bridge to transplantation. He has been continuously funded by the NIH since 1987 in the area of mechanical circulatory support. He also leads an R01 funded effort to develop an artificial lung. Bart continues to be active in the operating room and all forms of cardiac surgery with a special interest in aortic valve procedures. He has been an advocate for the development of bedside bowel engineers in support of patients on mechanical circulatory support and in the laboratory. Bart has been instrumental in the education of cardiothoracic residents for several decades. Please join me in welcoming him to deliver the Kent Trinkle Education Lectureship.
Thank you so much. It's a great pleasure to be asked by our president to give this award, and there are a number of reasons why I'm most happy to do so. You know, I think when you're asked to give a talk of this nature, it is something that makes one probably learn a lot. It's assumed that to give an invited lecture, you're an expert, and then when you sit down to write the first talk or the first slide, and you realize you're far from the expert, and you have to go back and you have to figure out why you were asked in order to put some cogent information on board. So perhaps as I wait for the first slide, I can tell you that the first slide is a kind of a montage of a surgeon, and lots of stuff around the surgeon, and lots of electronics and a lot of things going on. And I think that there are so many things going on in our careers right now that it's easy to get swept up in getting through the day, getting the next patient, getting the dictation signed, getting the referral call answered, getting to the bedside. And at the end of the day, there's really not a lot of time, not only for our own education, but for the education of those young people so integral to the next generation and the next progress that this specialty will create. So I think that I think it's important to have this lecture. I'm important in that it takes the 15 minutes assigned. It's now going to be a half an hour to give the lecture. And make all of us kind of just take a moment to appreciate what education is about in our specialty. So we're up and running now, and so that old surgeon is, as I mentioned, surrounded by a lot of stuff, and that's supposed to replicate the stuff that we're all surrounded by every day, and just trying to get through that day. So I would ask you, and it's probably unfair to ask this audience, because after observing yesterday and all the really neat mentorship that was going on with respect to the presenters, young people presenting established investigators and surgeons' work, This is not the question to ask this audience, but I will ask you to ask your colleagues, perhaps. Are you a triops? Well, what's a triops? You have to kind of drop back a little bit into your beginner's mind, your children-like mind, and you have to have a bunch of grandkids, like I now have, to go through the toy stores and begin to see all the neat stuff they have in toy stores. So I ran across this thing on the bottom left, which is a little packet. It's called triops. And triops are these little creatures that have been around for 300 million years. And the reason they've been around for 300 million years is because they're able to kind of exist in what's called an extended diapause. Cancer doctors know about diapause, but it's a cell that's kind of suspended. And these little creatures, they live in muddy ponds, and they kind of hang out in the mud until the water rises and they get kind of revitalized. So they're like seeds almost. And I use that to kind of indicate to you that I think all of us have this teacher genome. We wouldn't have gone into this work if we didn't love to teach. But I think sometimes, for some of us, we get into this phase of extended diapause. I hope to leave you today with some excitement about rekindling some water in your seedlings, if you wish. And of course, once you get that little creature growing, you have to continue to nurture it. It doesn't live well just with a little bit of glass of water. So when your kids bring these things home and you put water in them, you have to change the water and keep it nutritionally clean and see these little things grow out. It's really neat. So get a triops seed and have fun with your grandkids if you're blessed to have them. So maybe it might be that the eggs are teaching the chickens. What came first, the chicken or the eggs? I'm pretty sure, based upon what's happening at Maryland at least, that this young group of I-6 trainees are teaching all of us. And some part of my theme is going to relate to that, but in general will be applied to all trainees, be they traditional independent trainees, etc. But in our program, at least, the I-6 trainees have got everybody buzzing, and I'll mention to you as to why. So let's remember Kent. Kent Trinkle, fabulous surgeon, mentor, and it was interesting when I reviewed a little bit about Kent. In 1972, he gave the President's Award lecture at this meeting. 10 years later, he was a president. And then 10 years later, he gives an educational lecture that then becomes named for him. Pretty spectacular. I'm going to talk a little bit about the role models and mentors that have meant something to me and can be applied to all of you that fuel the fire. I'm going to talk about teachers' postures, which begin with the beginner's mind. Again, that triopsian mind, if you wish, brings you back to something joyful and young. The teacher's posture of creativity, and then the doer, or a bias to action. These postures came to me a little bit through George Kimball, who is the design school, the D School at Stanford's director and founder. George Kimball has a great insight into creativity and spawning creativity. And if you read anything on this subject or are interested in it, I would recommend you look up George Kimball. And then I'm going to talk a little bit about our reboot, my personal reboot at Maryland, and our attempt to build a culture of innovation. Well, as I mentioned, Ken Trinkle gave this lecture in 1994. And he titled it, My Way, A Celebration of Training for the University of Texas Health Science Center. And that was a spectacular presentation, and one that I'm not sure I could get away with giving today, but Kent has his own way, and he said things in ways that I think maybe this meeting would be the only meeting he could say it in. But one thing he said was, if you can't get your jollies, and he said the jollies from your residents' accomplishments, get out of the business. And then that speaks to altruism in our work. He felt, I think, before most of us, that 2 years of training wasn't enough, and he used the description of putting 10 pounds of manure in a 5-pound sack. He thought a book, a knife, and a patient doesn't make a training program, and I think all of us would agree. And finally, but not least, Surgery is like sex. A lot of fun, but not a spectator sport. So he used those as his primary views and his impressions as to how to build a program. Well, I ran into Kent almost that same year, and I was a young upstart and was describing a number of the pitfalls that we had gotten into in lung transplant, over 170 some patients at the American Association of Thoracic Surgery, and I found myself at meetings getting up and talking about failures, and it seemed like that was easy to get a paper on if you talked about failure, because nobody else talked about failures. But it seemed to me a good way to learn. And so we were talking in particular about airways, and Alec Patterson was probably in that session and will remember it, but we talked about this intussuscepting bronchial anastomosis for the lung transplant, and there was a fair amount of controversy about how to do it right. Important thing was for this talk that Kent Trinkle stood up, the first time I met Kent, and he agreed. He said, it takes a lot of courage to discuss complications, and I do think we learn the most from those. And then he zinged me. He said, I would like to make one comment on the silicone rubber stent. I have only used it 3 times. I really don't have nearly the experience as Griffith, as the authors, with anastomotic problems. So, okay. Well, let's get back now. We're off Kent for a little bit. Let's get back to what I consider to be the iconic role models. What a blessing I had in growing up in Pittsburgh in the dawn of Dr. Henry Bonson's growing department, which included Tom Starzl and Mark Ravage. These were 3 giants, and they were very different. And they all kind of had different postures that I personally could learn from, and others that gained similar experience did. Mark Ravage was really the philosopher, and he always wanted you to really think about the problem. Tom Starzl was a creative push, and Henry Bonson was the doer and very biased to action. Mark Ravage is shown here saying, ask the question, and I pulled that out of a Pharaoh's editorial that he wrote as long ago as 1983. It's a fabulous paper, very cogent to today, and it says, ask the question. So those of us that are in education, we need to ask our trainees to ask the question. Tom Starzl, again, this theme of not exalting from success, but to really focus on our failures, pulled out of a Many Sleepless Night, the wonderful book that he wrote about his career in liver transplantation. And then Henry Bonson, who was the most fabulous chief you could imagine. But he got away with it because he had so many good people around him in many ways. And he simply said to me one day when I was asking him all these really, what I thought to be important questions, and you never caught Bonson anywhere. He was always in motion. So the best place to find him was the men's room, and you kind of had to time it right. And so literally next to the stall, you would ask him an important question. I was hired next to the stall, and I asked this question next to the urinal, and it was about, should we do something wacky in transplantation? And he said, well, sure, just be brave. So with that kind of background, those kind of iconic models, it kind of set the stage for me in my career to try to model that in my own way, taking from each of these 3 one way or the other, and then to apply it to the training model. So in general, I think there's 3 principles that I want to leave with today, and it is that I think learning is more important than experience. I think experimentation is more important than planning. And finally, I think collaboration is far more important than individual excellence. And I think those 3 paradigms are important to keep in mind as you kind of find your way through your own career, but more importantly, as you begin to guide others. For example, this photograph was taken, unfortunately, shortly after one of the very early lung transplants in which we tried inadvisedly. It's the first lung transplant, heart lung transplant actually. We inadvisedly tried to remove the lungs from a distance when everybody else was moving the donor into their hospital to take them out. We hadn't learned from the lessons of then Toronto, from Joel, how to do it well simply with ice. But But we were trying to get these lungs and hearts to work and bring the organs in, not the donors. And we had an abject failure with this particular patient. As you can see, we had to remove the organ afterwards, and it was just an edematous blob and not functional lung. So we went to this idea, and we went to autoperfusion of the heart and lungs when I was a young guy. And again, that infrastructure of be brave and think about the problem and, you know, don't worry about your failures, figure out how to be successful. That all combined to have this experience early on in my career of taking this auto-perfusing heart and lung out of a donor from a distance. The heart never stopped. The lungs were ventilated by a recipient. Heart was beating into this reservoir. So we took normothermic lungs out, and then we were able to bring them back, usually in an aquarium-like structure, and then implant them. Well, one of the very important parts of this story, of course, is the guy pushing the wheelchair here, pushing this this heavy auto-perfusing heart-lung block. It's Bob Hardesty, and Bob Hardesty taught me to be a heart surgeon. He didn't teach me as much of those other things, those iconic visions that I still carry, but he taught me how to be a heart surgeon, and he had faith in me. He was what I would consider to be a teacher. So you don't have to be an iconic visionary to have a major impact. Just take care of your people and pay attention to them. Make them important. Well, now we reboot to Maryland, and leaving Pittsburgh after maybe the best of my years, I don't know, relocating at Maryland, I found an institution that was pretty short on tradition. And it was a training program that was struggling. It clearly was a program that was struggling with its clinical volumes. There were only 600 total cardiac cases being done, and only 300 of those were open heart surgeries. When I arrived there, it was a program, you know, that was in the city with Bill Baumgartner's strong program and surrounded by good private practice. So why did I go? Not sure, but it was a challenge. And the tail of the tape is not yet to be measured, I guess, but anyhow, we began to build our program first before we worried as much about building the training program, because we needed clinical excellence to draw in the chickens, or the eggs, if you wish. Now to do that, and Jim Gammy gave me a nice reference to an article that he found in the Harvard Business Review, and I don't know why Jim is reading Harvard Business Review, but it kind of scares me. But it was very appropriate because we divided the labor within our institution. We had a mitral surgeon, which became Jim. We have an aortic surgeon. We had a coronary surgeon. And we began to try to build expertise within a region, an environment where we were surrounded by really good surgeons. And so we needed to find how we could then compete against these established programs. So Thomas Malone is writing, it means breaking work previously done by one person into more specialized pieces done by several people. Whether or not those pieces are outsourced or distributed, their separation often leads to improvements in quality, speed, and cost. So we have one surgeon doing 250 mitral repairs, and the rest of us may do 20 total, just because they happen to be part of another procedure. So we use that, and by focusing it, I think we had the infrastructure set such that our trainees, when assigned to Dr. Gammy, would have a full experience in mitral valve repair for the 3 months that they were on that experience. Worked for me. That then led to some wonderful publications from our center, and who would have guessed, and Jim wrote this nice paper for the American Surgical Association, mitral valve repair nearing perfection. He said that because he didn't have a death and had very good outcomes. Jim is shown right here in his most important posture, which is life balance, if you wish, with one of his boys. We recruited Johannes Bonatti. Well, why? Well, I don't know whether I believe in robotic coronary surgery or not, but I did always applaud innovation and where is the future of coronary surgery going, and Maryland needed to be part of it. Well, that led us to try and basically say, is there going to be a role for robotic coronary, and if so, we want to be part of it. And you can see that this is a training module. You can train people to do it. Very complex, my goodness. I mean, I'd walk in there and shake my head, but then when I saw the expertise, the precision capable with that robot in an expert's hand, I said, well, maybe this will work. So Dr. Bonatti went on to write about this many, many times and continues now in his new role in Dubai to lead a whole hospital with that concept. So here's a nice circulation paper, not a bad place, not a bad address to send a surgical paper, and authored by Johannes Bonatti. And finally, because you know what I do, I'm not a robotic guy, and I've always kind of found my way in heroic, if you wish, heart failure surgery, and so we still continue to try to add to that literature in a humble way at Maryland, and we're pleased to do that. So you build the program with volume, you build the program by specializing, and then you publish. And then you find out what sticks. And then recruits, the trainees, begin to hear about you. And you begin to refer them to us. Well, with all that stuff going on and all that specialization, this dog doesn't hunt anymore. This was an earlier picture between transplants back at UPMC, and this was the transplant team. And I'm not sure I want them to be my transplant team for the next procedure done just sequentially. But that's what it was like. That's how most of us grew. It's no longer appropriate. So we have to build into the process not only all this hyper-specialization, if you wish, you know, where the bags of maneuver are going to go. We need to think about how we're going to do this, and the 2-year phenomena or 3-year phenomena to me isn't enough. So we go from there to needing more time or more bags, one or the other. And one way to look at that would be through this. And this is kind of my way of doing this. Most of you know this thing. And this is the greatest Lucy skit ever. But I think it's relevant to what we're being asked to do. And in just a minute, you'll see Jim Gammy comes in, our new division chief, and he straightens this whole thing out. So these are our trainees, and they're just gobbling what they can. There's so much to learn. Jim comes in. So you're being asked to, you know, we're all a bunch of fakers, that we're not overworked, we're not tired, give me some more, please. But you know that's a lot of BS, and so there we go. So the backdrop of all this, and I'm going to try to speed it along because I had a slow start. I went back and queried the national matching programs as an indicator in terms of what was the infrastructure we had, you know, to work with. Have all this tough work coming on, specialization, work hours. What was the infrastructure we had to work with in terms of the trainees? And if you look at the CT applicants per position offered on this upper slide, you can see that there were fewer applicants than there were positions. Okay. So that's why it's a 0.9 instead of a 1.2, right? Because the denominator is the position number. So it's a small number. That's not good. You want that number to be high if you want a selective program. And for the U.S. grads in 2012, note that it's 0.6. Holy cats. So basically, if you have a birth certificate, you can be a heart surgeon in this country. You know, it's not hard to figure that out. You can see the percent that matched, 97.5%, not hardly a selective specialty. When you compare between plastics, dermatology, ortho, and neurosurgery, you can see their numbers fare a little bit better. They're all over 1, which means there are fewer places, obviously, than there are candidates. What's happened to the I-6 program? Pretty cool. Bang. The I-6 program is the most selective program of all the match programs that was listed last year. 2.0. And of the kids that wanted into an I-6 program, 40% of them matched. I think we're into something the right way. If we looked at the American Board of Thoracic Surgery, and Bill Baumgartner, I thank you again for providing some of this data to me. The written boards are shown in the gold, and the green lower one is the oral boards. And you can see that our pass rate is not exactly good. And I think that having given the boards a couple times during the lowest oral points were 65% passed, I can tell you that they were fair tests. They were a fair test of whether somebody was prepared to pass the test. And if only 2/3 are prepared, something's wrong. It's getting a little bit better, but you can see we're in trouble unless we change a little bit. About the same time all this was happening in Maryland, I recruited Bob Poston, and Rob's gone on to be a division chief at the University of Arizona, God bless him. But he actually was the one in our program that pointed out to us that medical students are wonderful. And you wouldn't believe what Rob Poston did with medical students. He came to Maryland, he was given 50% time to develop coronary surgery for the future. And during that time, I think he had every interested medical student you know, at least been interested in cardiothoracic surgery at his coattails. We called them the Postonites. And there were half a dozen kids, and one of them has stuck and is our #1 I-6 trainee now in his 4th year, and he's a fabulous trainee. But it's this kind of attention. You don't only have to pay attention to your prospective your trainees, but it's these kids that are in medical school. And once again, Bill Baumgartner has lectured on this many times. So let's not pay attention to that very influential, very influenced group of people. I know I lecture to the medical students every year, and after that I get about 7 or 8 emails, can I shadow? And I recommend you go see your dean and say, I want to talk to our medical students, or to our first-year medical students. What about the intellectual capital differences? This is a tough specialty. You don't do well unless you have a brain. It's not all about the hands. And quite frankly, if you compare in gold, which is our independent 2-year program over the period between 2002 and currently, if you compare the USMLE scores in that group to the USMLE scores in the green, which is the I-6 current enrolled in Maryland, and the applicant group to Maryland in blue, you can see a significant difference. These kids are bright. They can take tests. I believe there is something about taking tests, but I think you have to have pretty smarts to do that well, whether you're a good test taker or not. So you can see a significant difference in what I call the intellectual capital relative to how we're going forward. And the I-6 pool clearly is younger. I mean, goodness, when were you most creative? I'll ask you. Were you most creative when you were 40? Probably not. I know I wasn't. So, you have to give a damn about the people who work for you, and you have to show it. That was the last admonition that Ken had given us in his lecture. And I like to transport it a little bit, so I'll put that hat on him. Okay? And that's Dr. Seuss, and he's my favorite author because he's absolutely crystal clear. And he says, in the end, unless someone like you cares a whole awful lot, nothing's going to get better. It's not. Pretty true.
There's a fire starting in my heart, reaching a fever pitch, and it's bringing me out the dark. Finally, I can see you crystal clear. Go ahead and sell me out, and I'll lay your ship bare. See, I'll leave with every piece of you. Don't underestimate the things that I will do. There's a fire starting in my heart, reaching a fever pitch, and it's bringing me out the dark. The scars of your...
Thank you.